to share with you methods of working with children with behavioral challenges. I have been doing this for over 30 years and giving workshops on it for over 20. I started by working with kindergarten and preschool teachers who had children in their class who were not yet diagnosed but had severe behavior problems and probably wouldn't be diagnosed till they got to like second grade. So right while they were teaching preschool or kindergarten, the people in my classes have kids who are really bringing the whole class down and at the best developmental level, but they have a 1:30 ratio. And I started teaching them for BER, the Bureau of Education and Research, how to use behavioral and sensory strategies. After about 10 years of that, I found there were things that I really wanted done with the kids that I didn't feel comfortable having teachers do. So I started training occupational, physical, and speech language therapists to teach the teachers. What you have on this page is all my contact information. I have a 17-year-old son and he always owes me money. And he said, Dad, I don't want to pay you back, but I'm going to make you a website because like you're really old and people now are young and they go on their smartphones. So I'll build you this website, won't owe you to 40 bucks. And he built me fabstrategies.org. I thought it was kind of cute, but it's really given me a way to communicate. You'll see a few last minute changes that I put in brown, and you can get those on fabstrategies.org under Fab Resources. So it's kind of cool. Also on the bottom is a YouTube channel he made me, and that has all my treatment videos. So you're going to see a treatment video of me with a 21-year-old who has autism, behavioral challenges, and tactile defensiveness. And if you want to study that treatment more, you can just go on YouTube. I gave you a bunch of big bang for your buck resources. I want to point out a couple. Starting with down near the bottom, you're going to see positive behavioral support help. I'll be talking a little bit about ways you can help teachers. And one of the best ways is to have them go on this, www.pbisworld.com. When they click on it, they'll think of a problem that they have, like a bashful child or a child who talks out of turn or has oppositional defiant disorder, they think, and then it'll give them questions. If they answer yes to 3 of those questions, then the kid does have that problem. And then they could look at tier 1, like whole school kinds of things, whole classroom, tier 2, small group, and tier 3, individual, like OT or counseling kinds of strategies that can be done with the kids. The next one that I want to talk about is www.qsti.org. It's something I got certified in. That's a research-proven massage for preschoolers with autism that improves their behavior and social skills. The next one is SHAF, Clinician's Guide for Implementing Air Sensory Integration. I don't use sensory integration anymore. That's what they do in clinics where the child leads the session. What I do is sensory-based interventions, but I find that my whole experience going deeply into sensory integration theory makes me better at those. And it's just a wonderful book. And then the last one is Stammer and Senrich, Classroom Pivotal Response Teaching. There's this thing that you've probably heard of, ABA. It works real good, but it's not practical. And some of the practitioners, I feel, are not respectful to occupational speech and physical therapists. There was this expert in ABA who studied under Lovaas, who was smart enough to marry a speech therapist. They got together and developed pivotal response training or pivotal response teaching. A lot of people haven't heard about it because they're bad marketers, but it has more research support than ABA. They're respectful to parents and therapists, and they use the developmental challenges of improving developmentally, motivation, generalization of skills, and self-control. So their emphasis on those things make them helpful not just for kids with autism, but a lot of kids who you're going to be working with behavioral challenges, especially if they have autism or a speech development problem. My curriculum I call FAB strategies is functionally alert behavior strategies. Whether it's being used by teachers, therapists, mental health therapists, or all of us, it has 4 parts: environmental adaptation, sensory modulation, positive behavioral support, and physical self-regulation. The way that that looks, if you look at section A, environmental adaptation, is the first thing listed there is a sensory coping area. This is just an area of a classroom you make. It might be a chair and table with masking tape around it. In a regular 5th grade, if a kid is irritated on a particular day, the teacher can have him sit there to do his work, and no other kid can go back there and tease him. In a very disabled kid, I might have a pup tent in their house where they can go that optimizes the sensory input for that child to learn. The next one down says ear press and weighted blanket. Ear press is a technique just for OTPT and speech therapists to both do and learn and teach to others. So I might teach ear press to a teacher, but they're not going to do it themselves. I might allow a teacher to use a weighted blanket after I teach them, but they're not going to use it themselves. So you put an X on that line and underline what you want them to use. In sensory modulation, I'll be showing you how to teach children to understand what their arousal level is, and if they're able, start to change it. So that's a sensory modulation technique. And I would check it off and underline it if I wanted them to use arousal level. If I wanted them to modulate their arousal level, do push-ups when they were hyper so they didn't become violent, then I would underline arousal level modulate. Positive behavioral support, one of the strategies is ask permission to kid with people or ask permission to touch people. A lot of our kids will slap you and then say, I was just kidding, like you can't punish me. Or they kid in an inappropriate way that gets them hit and stuff by other kids. So I tell them, you're not a good kidder, so I want you to ask permission before you kid with people. So they'll say, can I kid with you? If I say no, then they can't kid with me. But if I say yes, they can. The same thing with inappropriate touch. I'll say, please ask before you touch people, because me being 60, I have kids who I let like just hug me and stuff when they were 3, but now they're 22, they weigh 300 pounds, and they grab strange women at the fair, and the women scream for the police. So even when I'm working with preschoolers, I ask them to get permission before they touch. And I'm an OT, I model things, I'm a Italian, I am an occupational therapist, I do massage, but I never touch a kid unless I say, can I touch you? And they say yes. So I'm modeling that behavior. Physical self-regulation is like pushing a wall or wall push-ups. And then if you go all the way down to the bold black, crash pads, scooter boards, suspended swings, those are things for therapists to use. And you'll go through and pick out the ones that will best help a child. And in this way, OTPT speech and teachers, as well as parents, can all literally be working off the same page. The other way that I use it is to jog my memory. If I give equipment out, like a fidget, On the first row of environmental adaptation, I'll circle fidget, so I know I gave it out to a kid. And as I'm treating, I'll write down the things that work and underline them. Then when the kid gets transferred to another school or another class, I just give them a sheet with however many things I want them to have. In a home program, instead of a sensory diet, I'll pick a couple of these that I'm sure will work, and I'll send them home. It has the kid's name, your name, and your contact work email, and then your goal, like increase safe hands, improve waiting before shouting. And then you write the date. You'll underline a couple that you want the parent to use or the teacher. If they say, I lost it, you'll just take your copy and give it to them again. Then if they say, I did everything you gave me, I need more, then you can add to it. That way you're not spending a lot of your clinic or school time on home or teacher programs that are not going to be done. A couple of resources that I would like you to have is the Functionally Alert Behavior book on Amazon. So I'm not going to go into how to use FAB strategies because it would take several hours, but the book explains everything. And if there's a strategy you don't know what it is, it tells you what page it's on. Also, if you live in the greater Massachusetts area, I'm going to give a free workshop that's going to build on this one, like a part 2 to this, and it'll be from 9 to 11 for free at Therapro. It's a real fun thing. Usually people come and she gives them a certain percentage off and they bring shopping bags and just go through the warehouse. I'd like to quickly give you a few ways to assess behavior. And when I worked in a clinic, we were only given a half-hour billable time for evaluations, but we couldn't treat until we'd evaluated. So the insurance company kind of had us. And I said to the owner, I want to add a behavioral assessment and a sensory assessment for every single kid. She said, you can, John, but it can't take any billable time. So that's what I did. I gave a quick check sheet, behavioral assessment, and a sensory profile. And our receptionist often had time in the middle of the day when she had nothing to do. So I taught her how to grade the behavior assessment and the sensory profile. And I gave her a Dunkin' Donuts gift card every month for correcting them for me. So the kids handed them in as part of the entry assessment, and then the secretary would grade them, and then I just threw them into my eval. You want a behavioral assessment that's standardized, norm referenced, and strength-based. I'm using the DECA. It's a positive behavioral support program, but you can really use anything. I'm certified in it, so they let me use it for free. So I'm using it as an example, but I'll tell you some other things you can use. Takes only 5 minutes to score. The parent and therapist or teacher can score it, but it's the same form and we just correct it differently. There's an infant toddler one for birth to 3, and then an equivalent is the Devereux Behavior Rating Scale, 5 to 12 and 13 to 17. These are forms psychologists use to label kids social emotional maladjusted in school, and it's the same exact form. The same people did the birth to 3 and the preschool Devereux that I'm showing you, as well as the 5 to 12 and 13 to 17. It's just different items. If you don't have a DECA, you didn't get one for free, you can use the Ages and Stages social emotional and the ITSY and BITSY, which we use in birth to 3 as a screening for autism. I gave you one, and what the parent or teacher does is just say, how much in the past month did my kid act in a way that made adults smile or show interest in him or her? If never, it's a low score for attachment. It's not Freudian attachment. It's do you use teachers the way you're supposed to, or do you slap the teacher if they mark a question wrong? Choose to do a task that's challenging for him. Occasionally, so it's a medium score for initiative. A lot of kids with Down syndrome had no behavior problems, but very poor initiative. So I had to work on that. Listen to or respect others. If kids never listen to or respect others, that's a low score in self-control. Internalizing behavior concern is something that therapists notice and many other people don't. This is the kid who is the perfect kid and then tries to hurt himself or does something risky or stops coming to school. They have behavior concerns, but they take them out on themselves. This would be a kid who, as a preschooler, always fails to show joy at a happy occasion. At birthday parties, they're never happy. That would be a very high concern for internalizing behavior concerns. And if a child touches children and adults inappropriately very frequently, that's an externalizing. So as you look at these, you would then just rip this off. So if a child never acted in a way that made adults smile, they'd have a low attachment score. If they occasionally chose to do tasks that were challenging for them, they'd have a low score, low medium for initiative. And if they never listened to or respect others, they'd have a low score for self-control. You want attachment, initiative, and self-control to be high because research has shown that kids who have some neurological problems or developmental disabilities or whose parents hit each other or kids who have some malnutrition, if they have high initiative, attachment, and self-control, they're likely to do better anyway, despite these risk factors. If the child always fails to show joy at a happy occasion, it's a high behavior concern. We don't want behavior concerns to be high. And again, if they very frequently touch children and adults inappropriately, that's a high externalizing behavior concern. I put this right on my OT eval, and in the body, I talk about anything that's very frequently, like item 8 and 9, and then I give the summary score. You can see this child at home has very low initiative, self-control, and attachment. It's 2 standard deviations from the mean, so I know that it's very, very problematically low. Behavior concerns at home are as high as they could be. However, at school, the initiative's average, the self-control is below the jagged line, so it's a concern, but just barely. Attachment is almost a strength, and behavioral concerns are a concern, but just barely. That's telling you that the teacher is doing something that makes especially initiative better in school. So you just hand the parent a form, building initiative. It comes with the program, and it would say, have one meal together as a family. She'd say, with the TV off? I say, yeah, you'll live. So have one meal together as a family every week with the TV off, and that will build initiative. For things we as therapists can do, if they have low self-control, we can have them play games like Simon Says, or just implement in our OT or PT on the Jumbelina red light, green light, and you have to stop at the red light. And we can, for attachment, we can spend individual time with the child, ask the child to help us with something, comment on something we like about the child in particular. This one, feel free to ask questions. It's a little more complex, but I know that at Therapro, I get advanced therapists, and I think this is really worth learning. So if I haven't explained it clearly, please type in a question and I'll explain in more depth. This is something that I've given you, and it's called Questions About Behavior Form. It's a quick check sheet. You answer the questions, and it gives you a score. And your score that's highest is the reason the child's doing the misbehavior. When I have a child in a school, say he's on a behavior program by an expert and he keeps getting worse, or I'm giving him therapy, I think I'm doing all the right things, but his slapping of other children is getting worse, then I'll use this form. You can fill it out, the teacher can fill it out, the parent can fill it out. Why this is so important is the research has shown that occasionally physical, occupational, and speech therapists make kids behave worse if, for instance, we're using sensory whenever they slap the teacher. We take the kid out of class and we do sensory things the kid loves. And the kid is slapping the teacher to get out of being in class. If the child is slapping the teacher to get out of class, and I take him out of class, which I sometimes have done, and give him sensory things he loves, I'm going to reinforce the slapping behavior. If, on the other hand, I use sensory correctly, and he's doing it for non-social reasons, the third one down there, you have attention, escape. If they're doing it for non-social reasons, they're doing it for sensory reasons. They also call that automatic reasons. They're doing it to self-stim. They're, say, banging their head because they enjoy the stimulation of the movement and the smacking. They do it when they think they're alone and there's nothing to do and when they're alone. So they're not doing it for attention. So in that case, I would figure out why the kid was slapping and could he slap something else like a drum. I would figure out why he was smacking, banging his head against the floor, and could I give him pressure on his head. But if he's doing it for attention, then I would give him attention when he's not hitting the teacher. And if he's doing it to get out of work because he's in pain or discomfort, or because he wants to get a tangible reinforcer, I'd work with my speech language pathologist and find a more appropriate way that he could ask for that. Page 11 shows you is that this child was pinching or cutting himself for automatic reinforcement, for the sensation that cutting is giving him, not for attention, not for escape, not for tangible. This is when a sensory input is going to work. And if you look at the items that caused automatic sensory non-social reinforcement, 3, he often engaged in the behavior of self-stim. He often, number 8, did it when he thought he was alone. He often did it when there was nothing to do. He often did it repetitively, and he enjoyed doing it when he was by himself. So he's not doing it for attention or to get a reaction or to get things or to communicate something. They found that this non-social automatic sensory, if it's the highest, it's a major function of the behavior, and that most hand mouthing is done for this reason. It's just important if hand mouthing gets worse when you're using a sensory approach, like I decide to use water play and I decide to use a chewy as an appropriate replacement for hand mouthing, which is breaking down a very, very disabled kid's skin, because he's doing it for automatic reinforcement.
John, just a question that came in. We have a question about what ages is this form geared toward?
This is geared toward very disabled children, and you can start using it right at preschool. So I've used it at typical preschool age, It's also used with older children with severe disabilities. It's telling you why they're doing the misbehavior. And I only use it if I'm doing what I think should be working and we're following a behavior program or we're following a sensory program and the behavior's getting worse. But you can always use it. It's not a problem. If a child is severely disabled or an infant, you're going to have to use conditioning in order to improve the behavior. And I'll talk about this more if people have further questions. But what came up for me was I had children who were 10 years old at a 1 month developmental level. And I wanted to teach these children to calm down, but we couldn't teach a word calm down that they could understand because of their very low developmental level. So we thought about conditioning. Remember Pavlov, Doug ringing a bell, and whenever he fed his dogs, he rang a bell. And it's unconditional that when dogs see dog food, they'll salivate. So he'd ring a bell, and he got to the point after he'd done it a lot where he could ring a bell and they'd salivate. So I use this. It's not research proven, but I found nothing else. So I started using it with my friends. We had a very disabled child. So the OT, when she was swinging the child and he was relaxed, would give him the smell of a Discovery Ball lavender and squeak it. The PT, when he was massaging the kid and the kid was relaxed, would squeeze the ball. And the speech language pathologist, when she played the music he loved and he was relaxed, would squeeze it. Then I knew the child's environmental trigger was me asking him to do something or approaching him. That's when he'd bite me. And his body trigger was he'd extend before he bit me, and he'd fist his hand before he bit me. I'm going to teach you how to find out from kids what it is, but with very disabled kids, you need to figure it out.
So a
And
couple of questions that have come in about that. One question is, how are we certain of the behavioral function? For example, escape. How do we know?
how do you know that it's to get out of work? Is that the
Yeah.
question?
Yep. So
So,
how are you certain of the function of the behavior?
good question. The way that you find out is if a child very frequently under escape, he very frequently engages in the behavior to escape work. That's one item that would indicate to me that he's doing it to get out of work. The other thing that I didn't explain well is you've got to be very specific. I always say it's something my mother could see as a behavior. So a behavior is screaming, a behavior is hitting, a behavior is self-cutting, a behavior is slapping. What I do, because often I want to solve everything, but I can't. So if a child is hitting other children, hitting teachers, swearing, then I take one behavior, hitting other children. I choose that because that's most likely going to get them kicked out of school. Principals don't really care if teachers get hurt. We do, but it's not as problematic as if other kids get hurt. And swearing's bad, but it's not as bad as the hitting. So you have to take one behavior. So I'm answering, say, for one behavior, like self-cutting. Does the child self-cut to get out of work? If he very often does, then I look at number 7. Does he self-cut when he's asked to do work, like get dressed or brush his teeth? Then I'll say, does he self-cut when he doesn't want to do something? And if he very frequently does all those things, and that's the score that comes out highest, then you know that he's doing it not for automatic, but for escape. Then you
All
would
right.
meet with the speech therapist and figure out how he could appropriately get out of work.
And another question that has come in is the OT the only one that can fill out this form, or can other disciplines or teachers also fill out the form?
Everybody can. Um, I like to have direct care staff do it. If there's a behaviorist and they're doing a program that's not working, I know that never happens, but supposing that happened, I would have them do this because they're going to be familiar with this and they're going to know that this is a research proven protocol. This is a very famous quick test made by this guy, Johnny Matheson, and he let me use this form in my book, but it's something that speech therapists will understand because we're speaking their language. I like it though because I can fill it out if I've only worked with the kid like for 3 hours, say once a week for an hour. But I would have the person who knows him the best and the person most concerned about the misbehavior. A lot of times I have direct care assistant teachers or direct care staff do it. Also parents.
Okay, and another question is there a rating scale that correlates the total number to the function of the behavior, and is this related to standard deviations?
Yes, but this is a quick screening. It's as reliable and valid as doing what they call an experimental behavior analysis, where a guy sits in the back of the room and watches whenever the kid does, say, self-cutting, and looks at what happens before it and after it, and does it many, many times. But it's much, much quicker. So then, if this doesn't work, then you could go on and do more testing, but very frequently, particularly for very disabled kids, this works. So if the sensory input is reinforcement, what she did was she had a circle, square, and triangle, and whenever the kids put the circle in, she gave them deep pressure. And pretty soon, the children only put the circle in. So what that showed us was that sensory input of deep pressure is reinforcement. Sensory input improves behavior when given to more appropriately replace non-social, which is sensory reinforcement, but it makes behavior worse if it's reinforcing like slapping or escape. Using sensory integration strategies by doing the questions about behavior function and the sensory profile, as well as a preference assessment, improved children's behavior. You can't just throw objects in a room. That's just throwing objects in a room. But if an OT, a PT, or speech therapist does a preference assessment as well as a sensory profile, and if there's problems with the behavior or questions about behavior function, then they can use this adaptive equipment to improve behavior.
A question came in about what specific ages is the form for, because it could be useful for teenagers with special needs. Where can we access the form?
I gave you a blank, but then I will put, I will give to you to give to them the exact reference to buy it. I bought the whole package. I think it was like $150, and it has a book and it has the whole thing. So you can try out this one page, and if it works for you, I'll give you the resources with Johnny Matheson because I purchased the whole thing and it's much more useful because you'll have all of the, what's the ages, what's the research. He's done like over 40 studies proving that this works and for who. And it becomes more complicated when you use it all the time. For instance, often children are doing misbehavior for both attention and escape. If they're doing it for both attention and escape, then the speech language pathologist and I put our heads together and we say, how do we get this kid to ask for attention and also to tell us when he's had enough attention and we should withdraw, like all done. This is especially seen a lot in children who have autism spectrum disorder, anxiety disorder, and slap people, are very violent. We're seeing a lot of this. And it's interesting because a researcher did a study on this and found that those children, what he proved using modern resources was the heirs was always right. The reason a lot of children who are sensory sensitive and have autism spectrum disorder and are violent are doing it is because they have a problem where they don't habituate. Sensory sensitive people like me don't like watches or rings. They drive us crazy. Most guys can wear a necktie because they'll not notice they have it on. Sensory sensitive people do. So when we have these children who have autism spectrum disorder, sensory sensitivity, and say are violent and have this lack of habituation, we find on the sensory profile that they're sensory sensitive, then what we want to do is sit them further away from others. Because if they're simultaneously touched and talked to by a peer, they're not going to pay attention to the teacher and they're more likely to be violent. Now, I would like to take a little bit of a deeper dive into sensory integration. I know many of you know this, but I want to explain the ways I explain it to teachers and doctors and to parents who say are on a second grade level. So I want to get a little more depth about how you can use sensory integration for behavior, and I'm going to model it like I model it to the teachers. I'm not down talking to you. I'm modeling how you're going to teach this. And if you have higher level questions, you're welcome to ask me. What I say
Okay,
to the teacher.
John, sorry, before we go on to that, we had a question come in. So you were talking about a lavender ball before we got cut out. Um, the question is, what happened after that? So she said, you said, talking about a lavender ball before, during OTPT sessions, but what happened after it was
Oh,
introduced?
I'm sorry. Thank you so much for that question. I then associated the lavender discovery ball squeaking with relaxation. And I test that by looking at the child when he's a little tense, squeezing the ball, and he relaxes. Now, I want to use this relationship, this please relax, that's going to work with a very young, primitive developmental level to get him to stop biting me. So, what I do is when he's showing me that he's upset, and what he usually does, and I'll talk more about this, is his environmental triggers. I ask him to do work or I approach him. His body trigger is he fists or arches, and then he bites me. I would like him to stop biting me. So when he fists and arches before he bites me, I'm going to squeeze the discovery ball. All that's saying is please relax, but I can't say that to him. If he then does not bite me, I'm going to reinforce him. I'm going to give him a cookie or something for not biting me. And the please relax, the squeezing the ball, and the smell of the lavender, he gets for nothing. And whether or not he relaxes to that, if he doesn't bite me, he usually bites me when I approach him, let's say, every time. If he doesn't bite me, I'm going to reinforce him. It's the reinforcement that causes him not to bite me. In the other example, because I think I left you hanging on that as well, if a child is sucking his finger raw, I'm going to give him a sensory replacement of water play and a chewy. I'm also going to do a preference assessment. I'm going to label number one a super chew with grooves, and number two, a smooth super chew. Whichever one he grabs and bites is the one I'm going to circle as his preference. You're using the sensory replacement you choose and the preference assessment, and then you're giving that to the kid for nothing. They use a fancy word. So if you're working with a behaviorist, it's called non-contingent reinforcement with a matched sensory input. All non-contingent reinforcement means is you get it for nothing. A matched sensory stimulation is what we do all the time. You try to figure out what he's getting from the inappropriate behavior of sucking his thumb raw, and you find a more appropriate way. What Ayers said was it's like a short circuit. My son sucked his finger once, got what he was going to get, and never did it again. So if you're continuously doing it, we've got to find something else. Then I'm going to give him an additional reinforcer if he goes longer periods without sucking his thumb. What I say to teachers is that sensory integration or sensory processing disorder are the same thing. And under the same thing is two things that affect behavior: sensory modulation disorder and sensory discrimination disorder. First, we'll talk about sensory modulation disorder. This is when you're sensory over-responsive and you don't habituate, you don't get used to stuff. And this is the research that I was talking about. Green et al. 2015 and 16 found that these children, and I'm seeing a lot of them, who have autism, they have anxiety disorder, and they have sensory sensitivity on the sensory profile, had decreased amygdala and sensory cortex habituation. And as a result, you want to sit them further away from other kids, because if they simultaneously are touched and talked to, they're going to get more and more and more hyper aroused. And you don't want that to happen. Sensory underresponsivity, also called low registration or hyporeactivity. They don't notice sensory input and they get used to it fast. Sensory seeking, we used to think, was kids who were sensory underresponsive and wanted to get this party started. That's true, but also some kids who are sensory sensitive begin sensory seeking, trashing your therapy room, getting more and more discombobulated. The last one, some people say is not one. I say it is. It's sensory avoiding. Some sensory integration therapists say there is no sensory avoiding. I think there is, and you're going to see it especially in kids who have a history of post-traumatic stress disorder, where these children have learned to shut down and they just sit there like low tone and they don't do any work. This is something that I developed. And the reason I developed arousal level is that there's 4 systems. 2 are OT ones you probably know about. There's how did your engine run the alert program? Is your engine running high or low? There's zones of regulation. Are you in the red zone, the yellow zone, the green zone, or the blue zone? There's also the traffic light program that's widely used in elementary school with children with behavior problems. Red light stop, green light go, and yellow light stop and think. And there's a fourth system that's a trauma system called ARC, attachment, self-regulation, and competency, where you're high energy, low energy, or medium energy. And I found problems where children are taught one system in preschool, another system in kindergarten, another system in first grade, another system in second grade. All those systems are great as long as they're consistently used. I developed my system and I'm giving it to you, and you have a permission to use it. I gave you on my website under resources one without page 14 that you could use for personal treatment use. I find some of my children can't understand and they're getting angry because they're taught different systems by different therapists. So I teach red, cherry scent, which is over responsive, hitting people, heart racing. Green, which is quiet, alert, responsive, the way you want to be in school, and that's apple scented. And then blueberry, a blue light special. And the blue light special is when you're shut down, you're under responsive. Often it's not a good place. Some kids self injure in blue. Some children won't leave their rooms in blue. Some children skip school in blue. So if you're in blue, you want to do jumping jacks and getting green. If you're in red, you want to do push-ups or carry notes or books, boxes of books for the teacher. So you have linear movement with joint weighting, proprioception through the joints for calming to a quiet alert. If a child doesn't have blue, just use green and red. But if they have blue, I use red, green, and blue. I find yellow is sometimes too hard for my children. If I can use yellow because they're bright enough, then I use banana flavored. You can go on Amazon.com and buy, my son taught me, and buy a banana that smells like a banana and buy a strawberry that smells of strawberry for red, and you use those and they give you the free 4 colored markers that are scented: red, yellow, green, and blue. Always use the same smells. This is an example of the ARC system because I figured some of you may not be familiar with it. When children are significantly abused in the first 5 years of life, it's often referred to as developmental trauma. It's not yet a diagnosis, but it changes the brain, particularly the self-control prefrontal areas and the corpus callosum. And so they teach high energy, medium energy, and low energy. And again, I match it with the colors. So we're using the same things. I add red for high, green for medium, quite alert, and blue for low. What I want to point out for you is there are some times that we take a kid who's hyper and gets violent when he's hyper, and we're trying to calm him down, and he's fighting us. He doesn't want to calm down. And I've always said to myself, what do I do? He's fighting me. I'm never going to do it without his consent. What some kids will say using this scale, what I would say is I feel high energy, and that's not okay because I'm talking too fast and my heart is racing and I'm not going to be a good teacher for this group. But if a child says he's high energy and feels okay about it, feels great, and he's fighting you and doesn't want to leave high energy, that's telling you he's uncomfortable in medium energy. What that could be, for instance, in extreme cases, is some children were abused at night when they were sleepy. So they'll never let themselves go out of high energy. Another example could be just a kid who's so hyper that they've never been in medium. What's that telling you as a therapist is that you need to go down slower and, if possible, in a one-to-one situation, because they're going to feel uncomfortable going to medium. So you take them from super duper hyper to super hyper, or you take them from super hyper to just hyper. Instead of doing jumping jacks extremely fast, they do them just fast. If you're doing a yoga group, you go from very fast to just fast, or from super fast to a little fast. The same thing for low. You can go from very low, doing nothing, to just low. But you're not going to succeed if you try bringing them all the way to average in one swoop. So if they're fighting you, think about going more graded in smaller steps. And if you can, working with them one-to-one in a more secure environment. This is an example of how I use the cuddle swing in schools. Often in schools, you're not going to know if kids have trauma disorders. It may not appear on the school record. So you're going to have to kind of look for it. What I tell, again, teachers is that in the normal population of kids and adults who have no diagnosis, 5%, 5 out of 100, have sensory problems. But in children with ADHD, oppositional defiant disorder, depression, it's 35%. So depression isn't the same thing as sensory integration difficulties, but you're more likely to have it. In autism spectrum disorder, 90% of those children also have a sensory integration problem. So I want to test for it, but it's not the same thing because 10% of them don't. Just a reminder here, gravitational insecurity, being scared to go on a balance board, being frightened to go upstairs, that's hyperreactivity to movement or vestibular stimulation. It's different than postural problems or cruddy balance. What gravitational insecurity is you're afraid you're going to fall because you have oversensitivity to movement. And the way we treat it, this is a class at Sacred Heart. And the girls and the parents are working with this kid who has autism and who has gravitational insecurity. But someone's holding him. They all have him surrounded. When he falls, they've got him and he's okay with it. You're like a
John,
yeah.
a question has come in about what are your resources for those number of populations that have sensory processing issues?
I took it out of a paper by my favorite person. Let's see if I can quickly uplink it. It's two things. There's a 2016 paper by not Winnie Dunn. It's a 2016 paper by Lucy Jane Miller. And I'll send that to you also. You can send out another set of handouts, right?
That may not be necessary as it's not uploaded into the, but maybe if it's accessible on your website, that would be
Yes,
a
I'll
best
put
way.
it under Fab Resources and it'll be up by tomorrow night. So I'll put under Fab Resources another paper. What you're going to see under Fab Resources is one paper that kind of says webinar, and I'll say new webinar information. And what you'll see is 3 colors, and the 3 colors show how problems with oppositional defiant disorder and other things correlate with problems with sensory. I'll also list all my references. I have several. So I'm going to put that up for you. It's taken from several references, but it's very interesting because it fell at a very easy way to teach. It's about 35% from all of the papers for all of the mental illness. And there's a few different things. There's a preschool study about sensory sensitivity and diagnoses, usually anxiety. There's another study on the correlation between oppositional defiant disorder, ADHD, and sensory problems. So I'll give you several of those resources. And luckily, they all come out about 35%
Okay,
for
to
mental
go back
health.
to your last slide that you were just on, we had a question about, could you repeat what exactly gravitational insecurity is? Afraid of movement, fear
Sure.
of falling, over responsiveness to movement. The question asker just wanted to double check on that.
Gravitational insecurity is hypersensitivity. We were talking about sensory modulation. Under sensory modulation, there are 4 problems. If you got any one of these 4 problems, you got a sensory modulation problem. Gravitational insecurity, and the next one I'm going to talk about tactile defensiveness, are sensory over-responsivity to movement, which is vestibular. That's gravitational insecurity. Gravitational insecurity is hypersensitivity or sensory over-responsivity to movement or vestibular input. And tactile defensiveness is sensory over responsivity to touch. And mostly in recent years, people have correlated sensory integration as meaning just sensory modulation disorder. That's not true. There are 3 kinds of sensory integration or sensory processing problems. The first one, sensory modulation disorder, which I'm talking about now. The second one is sensory discrimination. And the third one is sensory-based motor disorder. We're not going to go over the third one, sensory-based motor disorder, until the next seminar, the one in Massachusetts, but I am going to explain the order I treat it in. So gravitational insecurity is when kids are oversensitive to movement. And what Ayers always said is it's going to make you neurotic. What recent research has found is it does, in fact, make you neurotic. People who are gravitationally insecure are more likely to be anxiety disordered. If you counsel them, their gravitational insecurity gets a little better. And if you work on their gravitational insecurity in sensory treatment, their anxiety is going to get a little better. How you treat it is if it's a baby, you throw the cushions, with permission, from the parent's couch on the floor and you have the kid crawl over them. You do like a good mother. You tense the child, but just an iota, because if you tense him too much, you're going to upset him. So you make him just a little uncomfortable, but you're very clear that he's safe so that he can have fun with falling. If you scare him too much, you're going to have a problem. The thing I like, the sensory profile and the sensory processing measure both do a nice job of looking at sensory modulation. The reason that I've always used the sensory profile is it does from babies to adults. So if you're in birth to 3 and you have a child who has autism and sensory sensitivity, and the mother doesn't like playing with her child, you can do the mother sensory profile and see if she also has sensory sensitivity. The other thing I like about the sensory profile is the new one called the Sensory Profile 2 lets you, the short sensory profile 2, lets you discriminate between sensory problems and non-sensory problems, like screaming tantrums. But what it's brought up for therapists is, can I still treat if it's a non-sensory problem? What if the scores show that they have a problem around their behavior in non-sensory areas? And I just wanted to give you a few strategies from mindfulness that are very effective for children who have non-sensory problems. This is one that I simplified from mindfulness. It's called a meta. I'd like you to just try it so you can experience it in your body. And I invite you to close your eyes. And I want you to think of a child or a parent or a dog or a cat, some being that you unconditionally love. Get their picture in your mind. May they be happy. May they be healthy. May they be at peace. May they be happy. May they be healthy. May they be at peace. May they be happy. May they be healthy. May they be at peace. Now I want you to think of a stranger, someone whose face you can remember, but you don't know them. A policeman that was sending traffic around a construction site today. A new security guard in the school. A waiter who you met at a restaurant, where you can conjure up their face, but you don't know them. May they be happy. May they be healthy. May they be at peace. May they be happy. May they be healthy. May they be at peace. May they be happy. May they be healthy. May they be at peace. Now I want you to think of yourself. May I be happy. May I be healthy. May I be at peace. May I be happy. May I be healthy. May I be at peace. May I be happy. May I be healthy. May I be at peace. Now I want you to think of all of us on this webinar. May we be happy. May we be healthy. May we be at peace. May we be happy. May we be healthy. May we be at peace. May we be happy. May we be healthy. May we be at peace. And you can open your eyes. What we're trying to do here is help children be a little more able to realize that other people are people like they are, which will make them less likely to hit them or make fun of them. It's called a meta, but I go very quickly. You can do this whole thing in like 5 minutes, and it's a great way to start a session if you have children with behavior problems. And what you would do is have them think of a dog or a cat if they can't think of a person, because you don't want them to come up empty. And I've had kids where they couldn't think of a person, but they could think of a guinea pig or a dog. Then you have them think of a stranger and then themselves, and then you and them if it's a one-to-one session, or the small group if it's a small group session. The whole classroom if you're doing it in front of a whole class. On the page where I gave you references, I gave you Susan Kaiser Greenland. It's a nice $10 book. What I did for these, the kindness, these questions to ask yourself, is I took her stuff for preschoolers and I made it easier. so I could use it with special needs people. Quicker and easier. You go as slow as you can, but as quick as you have to. What she says, and I go in developmental order, is before you speak, ask yourself, is it true? And I'll reinforce the kids for only speaking what's true. Then you go to, is it true and is it kind? If it's not true and kind, you don't say it. Then you go to, is it true, is it kind, and is it necessary? Do I need to say it? The last kind of side thing on behavior is trauma-informed care. When I work with kids, a lot of people think I'm joking, but I'm not. I do some things, and these things are called trauma-informed therapy. If kids are trauma-informed, if kids have had trauma, they're going to behave better if I do these things. If they haven't had trauma, they're just going to think I'm a nice guy and it won't hurt them anyway. So I do this with everybody. A lot of you in schools get stuck in different rooms. Sometimes you're in an unfamiliar room. What you can do is seat the student so they're facing the door. This helps children who have had trauma to feel more secure. The second game that I play is if you're sitting, sit kind of so you're in the room and you have two walls, and take your head and look at the left wall and rotate your head to the right wall. Do it again. Rotate your head from the left wall to the right wall and notice anything brown. Then rotate your head from the left wall to the right wall and notice anything green. If you have higher level kids, I would then go to turn just your eyeballs from the left to the right, from the left to the right and notice a color, from the left to the right and notice something triangular, from the left to the right and name everything you can see that's square. Then go left to right and give me everything from nature, everything made of wood. What that's based on is it's called scanning. It's giving them a chance to see the new room and get used to it. It's also doing something similar, some people believe, not well researched, but I like it, from EMDR, eye movement desensitization reprocessing. They would relive a trauma and have a kid move his eyes from side to side or drum his hands so that the trauma was less upsetting. And it's called scanning. When I'm disciplining the kids, and again, people think I'm joking and being sarcastic. What I say is, no matter what you do, I will like you. I believe that all children are precious. So I'll like you if you hit me. I'll like you no matter what you do. Some of your behavior I'm going to punish. There'll be consequences. Because if you keep doing that behavior, like slapping people, you're going to have a bad life, and I want you to have a good life. So I'm going to have consequences for that behavior because I think that will stop you from doing it and have a good life. Some of the things you do are going to make you rich and successful, and that's what I want for you. So I'm going to reinforce those things. I'm going to give you prizes or food if you do those things or extra privileges. But it doesn't matter what you do. I like you no matter what. The other thing is you don't make kids do things. If you go head to head with a child who has trauma, you're going to lose. So you invite them. If you're doing an activity, you invite them to do it. If they don't want to do it, they don't have to do it. They can't interrupt others, or there might be consequences, but they don't have to do it. Also, you would say, you can close your eyes if you want to. I'm going to keep mine open to keep you safe. So if you do eyes closed activities, you invite them to close their eyes, but say that you'll keep yours open to make sure they're safe. Those are trauma-informed care things, but they won't hurt if you just do them with everybody. I would like to give you one more mindfulness activity that's quick and simple, and then a high level one. The simple one is tense your face. So when I say go, tense your face. And then when I say relax, relax your face. Ready, set, go. And you clench your jaw, relax, and you relax and have a Gumby face so your jaw hangs out. Now I want you, when I say go, to lift your shoulders up to your earlobes. Ready, set, go. Relax. Let your arms just hang down, your chicken wing bones hang down, your arms totally relax. Now when I say go, I want you to fist your hands as hard as you can. Ready, set, go. Relax. Have Gumby hands like there's no muscles in them. They just hang, they are free, they are relaxed. That's based on a research-proven thing called progressive relaxation by Dr. Benson. But when they use it in the schools, they have kids relax their whole body and kids slap each other because it takes an hour. So what I say to the teachers is, the reason I do just clench your jaw, raise your shoulders, fist your hands, is a lot of children, when they're writing in 5th grade, if they have problems, and the kids that I see for OT, they clench their teeth while they're writing, or they grit their teeth while they're writing, or they stick their tongue out while they're writing, or bite their lips, or they raise their shoulders way up high all the time when they're writing, or when they're writing with their right hand, their left hand fists. That's an associated reaction. If I open a really heavy 50-pound door, my other hand is going to clench a little to help. If a preschooler has an associated reaction while they're writing and they're just learning, we don't worry about it. But if a 5th grader has been writing for 5 years and he fists his hands and lifts his shoulders and bites his lip when he's writing only, that tells me he might be working too hard to write. The next one has been proven for adults with autism to be very, very effective. Singe is the psychologist who has proven this over and over again with kids with Fragile X syndrome and other things who are violent. I want you to close your eyes and feel your feet. One foot. Feel your fat big toe, your next toe, your middle toe. You can't kind of feel mine, so I bend it. Your second littlest toe and your littlest toe. So you're either bending or feeling all your toes. Now I want you to go backwards. So you feel your toes, but you feel this ball on your foot. Go back and feel your arch. You feel your toes, feel your ball, feel your arch. Now feel your toes, feel your ball, feel your arch, feel your heel. Toes, ball, arch, heel. Toes, ball, arch, heel. And you can open your eyes. That's called feel your feet. I like it because your feet are always with you. The reason why children who are in their teens who text and drive simultaneously don't end well is they're not doing it simultaneously. They're texting, driving, going back and forth quickly. And that's what I want to use. I want to be mad at someone, feel my feet, or any coping strategy. Do push-ups. Whenever I'm tense, I do my coping strategy. And as children get more and more frustrated, I have them use their coping strategy. First, for a month, I just have them do it daily for 5 minutes. Then, when they're a little upset, I have them do it. And if they don't misbehave, I reinforce them. Then I beat them in a game. And if they don't tear my room apart, I reinforce them. So I have them use this as a relaxation. The last one I'd like you to try with me. It's for any of you who, like me, might have personal stress. It's really easy, so just go with me here. It's called counting your breath. It's a Buddhist thing, but it's real easy. All you do is when I say breathe in, breathe in. When I say breathe out, breathe out. And as you get better at it, you're trying to breathe into my count so you breathe in all you can when I get to 4, and breathe out to my count. So when I've counted to 6, you can't breathe out no more. Breathe in, 2, 3, 4, out, 2, 3, 4, 5, 6. In, 2, 3, 4, out, 2, 3, 4, 5, 6. In, 2, 3, 4, out, 2, 3, 4, 5, 6. In, 2, 3, 4. Hold your breath. 2, 3, 4. Out, 2, 3, 4, 5, 6. In, 2, 3, 4. Hold your breath. 2, 3, 4. Out, 2, 3, 4, 5, 6. Hold your breath. 2. In, 2, 3, 4. Hold your breath. 2, 3, 4. Out, 2, 3, 4, 5, 6. Hold your breath. 2. We call this 4-4-6-2 breathing because it's 4 in, 4 hold, 6 out, 2 hold. Another common one used is called square breathing, which is 4-4-4-4. The reason I have your out breath be more than your in breath is that increases relaxation. If the out breath is longer than the in breath, it increases relaxation. Where I want to end tonight is just to show you what this all means. And I'm going to leave time for questions because I've made this kind of advanced. And like I say, I invite you to come to the free one in Massachusetts if you want to build on this and ask more questions. But I usually get advanced people, so I went very fast. You can also email me questions. The reason I gave you all this information is that sensory modulation disorder in treatment is what you want to address first. Before anything else, a child might have sensory modulation disorder. That means they're low registration, sensory seeking, sensory sensitive, or sensory avoiding. If they're sensory sensitive to movement, they're gravitationally insecure. If they're sensory sensitive to touch, they're tactile defensive. Again, Lucy Jane Miller's my favorite. She has a game where kids put their hands on the table and you touch a finger, say their pointing finger, and they show you it's their pointing finger. Then you have them close their eyes and you touch a finger, enough to make it white for a second. Then they open their eyes and show you that you touched their middle finger. By 3 years old, someone should know which finger you touched. It shows they have an internal working model in their cerebellum of their fingers. They can feel them without looking. And that's part of sensory discrimination disorder. On a higher level, sensory discrimination disorder is writing on a whiteboard. When you write on a whiteboard, you have the squeak of the whiteboard. You have the smell, the stink of the marker. You have the proprioception of what it feels like to write the word bed, how your hand feels, and you have the visual of bed, and you have to put those all together. So we have our movement, vestibular, proprioceptive, and tactile. We also have taste, smell, vision, and hearing. And the new thing that we found you have is interoception. Like kids who are always in pain, always hungry, always thirsty, always got to go to the bathroom. Interoception can best be addressed through mindfulness. I showed you a couple of mindfulness things, and that's something that interoception addresses. So first I'm going to get the kid in a quiet alert state. Then I'm going to address sensory discrimination disorder. And hopefully I've got some physical therapists. What you're going to do is postural disorders, cruddy balance, a lack of a writing reaction, a lack of an equilibrium reaction. Before you address postural disorders, make sure they're in a quiet alert state and they have body awareness. Then go to postural disorder and working on praxis, which is coming up. We call it motor planning sometimes, but it's coming up with an idea, a motor plan, and an execution. So I just wanted to show you why I went over that in such depth with you. Because in treatment, if a kid's got all three problems, you want to make sure you go in order. First, fix sensory modulation and get them quiet alert. Then make sure they have body awareness and can put different senses basically together. Then you can work on dynamic balance, which is postural disorder, and different than being scared, which is gravitational insecurity, and praxis, which is doing something you haven't done 100 million times, like learn to tie your shoe, learn to print, learn to cursive write, learn to type. I'm going to turn it back over and answer any questions now, and feel also free to go on to my fabstrategies.org and email me, or go on to Fab Resources and get the handouts.
All right, so one of the questions that came in is, how can you tell if a seeker is hyper or hypo-responsive?
If they're hyper responsive, they're spazzy, they're running all around, and they can't sit still, they're talking fast, their heart is beating fast, they're kind of a spazzo. If they're hypo-responsive, I'm trying to get the picture because it's so wonderful. If they're hypo-responsive, they're kind of lethargic and laid back, and they're just low muscle tone. Their arms feel like overcooked spaghetti. They're not paying attention. They're not tuning in. Teachers
Yeah.
or wives will say to their husbands or children, I tell you and tell you and tell you, and it just doesn't register. So it's not getting through to them if they're
Oh,
low registration.
so another question that came in is, have you been able to do mindfulness with kids with low cognitive levels who can't visualize or understand terms in your slide 19? I've used with good success with kids without low cognition, and what is the term you use for this?
With kids with low cognition, I use massage as mindfulness, and I use massage for relaxation. I know some speech language pathologists and occupational therapists and physical therapists have stopped using touch, but I would urge you that it is within your frames of practice, in my opinion, and that it can be powerful, particularly with very disabled kids. And it can be very powerful because we're the only ones left that'll do it. With higher level kids, I might do something like press your hands together isometrically, like the Dalai Lama, or press your hands on the desk so they won't look weird. And they could do it in work instead of punching their bosses. Just do an isometric contraction down on their desk, or press their hands together. Even with higher kids, I might start with something they love. In the school, I like push-ups because men teachers think I'm punishing the kids. I'm not punishing them. I use push-ups as a coping strategy because it will help kids who are hyper-responsive and kids who are hypo-responsive, because it's linear movement with deep pressure through the joints. The other thing that's nice in the school is have them carry a box of books to the secretary. So they're loaded through their arm joints and they're moving, usually slowly if they have enough books.
Okay, another question is, many people in school settings will not do actual sensory treatment. They feel this belongs in a clinic setting. What are your thoughts on this? I'm having a disagreement with my colleagues now. they will only do accommodations?
Well, it's tough, but one of the things that I do is called sensory-based interventions. It's gotten a bad name, but it shouldn't. When I say sensory-based interventions, I mean a skilled therapist who's had sensory integration training uses just a suspended swing or uses just a study carrel, a clipboard, and a fidget. There might be times when we're using what you might call accommodations, or we might even use them as part of a behavior program. What sensory-based interventions are, in my opinion, is specifically using sensory strategies to improve behavior by addressing sensory modulation and sensory discrimination disorders.
All right, so we are definitely over time, but just briefly, we have a question on the eye movements. Is this a resource that's available on your website, or can you repeat it just very quickly?
I'll repeat it and I'll also put a slide like explaining it. I don't have a picture, but it's commonly used. Scanning is when you look from one side to the other with your head and then just with your eyeballs. It's called orienting game. An orienting game can get children unscared, particularly for my school therapists who are always stuck in it. I hope they don't ever do this anymore, but they used to always put me in a different room. So kids with trauma were always scared. What you can do is face them towards the door where they're sitting and play this game to get them used to the room.
Okay, and then very quickly, the last question that's come in is, what do you do with a child in a gen ed high school setting that has auditory over-responsivity but doesn't like the pressure of headphones or earplugs?
It's common. What I sometimes do is my sister used to give me allergy shots. She's a nurse. So she'd press on my arm and then give me the shot. It didn't hurt so much. So what I play with is I'll press on the kids' ears, shove the headphones on, and tell them that if they wear them for 10 seconds, I'll give them a candy. Then 20 seconds, then 30 seconds. When they can wear it for a little while and stand the touch, then I can see if the headphones will help them. The other thing is some kids are so tactile defensive, I use them just for fire drills. Very loud sounds that make them misbehave. The teacher keeps it in the desk, and as soon as there's a fire drill, she hands it to them, and they wear it. Because kids who are hypersensitive to sound are usually also hypersensitive to touch. That's why we have that problem.